Guillermo Chacón. Nos va a dar, Guillermo Chacón is going to give us a welcoming, so open plenary. He's the president of the Latina Commission on AIDS. So Guillermo.
Thank you everyone for joining us. I know people are coming into this virtual space as the nation bleeds right now, facing institutional racism, police brutality, social unrest. I want to remind that from a public health perspective, we have a lot to say, a lot to do. Be in solidarity, be in active solidarity, especially with Blacks, African Americans, and people with social conscience to challenge, the difficult times that we're facing right now. And our deepest condolence to those that has been affected, and especially to many families, but especially right now, George Floyd, who was murdered in a terrific way, and as many others have been facing death and police brutality. Anyway, with that in perspective, I wanna really, we will give more details about Reunion Latina, but we're very excited to have a giant among us. We respect very much the leadership of Dr. David Holtgrave, who is Dean of the School of Public Health of a very important university in Albany, State University of New York, since 2018. He has been also a key voice for us. In the past, he served, in the Presidential Advisory Council in the Obama administration. He testified in Congress. He has been always a voice of a source of direction, an important leader in public health, and we're so happy that Dr. Holtgrave will give us an update, his perspective, his reading about the horrible current pandemic that we face. Please help me welcome Dr. Holtgrave. You're among family and friends. Go for it.
Thank you very much, Guillermo. It's such an honor to be introduced by you. Thank you for that very warm welcome, and thank you for the wonderful partnership over all of these years. It's so wonderful to learn from you and to be a partner with you. Thank you very much, my friend. And thank you to the Latino Commission on AIDS for having me as well back to this now the virtual reunion, Latina this year. And if we could go ahead and show the slides, that would be great if you want to go ahead and pull them up. And as we do that, I wanted to say on the next slide, actually, that I'd like to dedicate my remarks, similarly as Guillermo mentioned, to the memory of Mr. George Floyd, his family, and to everyone who is working in the struggle against racism, individual and systemic, in all of its forms. We have to continue as a society to do better and to make real and lasting change and not rest until we see that. And so I think the whole conference, I know, will be very much in that spirit. On the next slide, I'll begin just talking a little bit about an update on COVID-19. And I know that some of these things are well established, so I'm going to really just hit the highlights on a few things and then really focus on health disparities, especially as they relate to Latinx communities. We see these in many different ways, and I'll highlight them as we go through. So of course, SARS-CoV-2 is the virus that causes COVID-19, the disease, and it's part of this family of coronaviruses that includes things as mundane as the common cold and as serious as MERS and SARS that we knew a few years ago. And this novel coronavirus, of course, is SARS-CoV-2. And on the next slide, we see a number of the basic facts about COVID-19 that I know you're all familiar with. What are the basic symptoms of COVID-19, which was actually recently updated by CDC to include 2 or more of a list like chills and shaking with chills and headache and sore throat and loss of taste and smell. So that's relatively new to the symptom list. And we're learning, I think, that the incubation period from infection to becoming ill is a few days, probably 2 to 14. And the disease severity is clear that for about 80% of people, it's fairly mild, but for about 15 to 20%, it's much more serious and often includes hospitalization. And we now can estimate that the infection mortality rate, or deaths divided by number of people who become infected with SARS-CoV-2, is about 0.5 to 1%. And that's different than taking the cases that are diagnosed. That's a different kind of fatality rate. But I really want to emphasize that the impact is very disproportionate by communities of color, especially for Latinx and African American communities. And we need better data in Native American communities as well, too. We're seeing signs that there are disproportionate impacts there as well, but we need more and better data to address the disparities in Native American communities. Clearly, this impacts older persons and persons with underlying medical conditions, but young people can become infected and become ill as well, too, and also can infect others. And we're seeing also an unusual syndrome among some children. In New York State now, there's been roughly 100 cases of this novel syndrome that can really impact young children as well, too. On the next slide, we see some statistics that are ever changing. And I have to say when I update this talk every couple of days, and this is the saddest slide to always have to update. Because just from one time period to 48 hours later, these numbers change and grow so much. We're now over 6.3 million people who've experienced this virus, have been diagnosed across the globe, over 376,000 deaths. The number of countries continues to change, and the US is still at the most impacted, but Brazil is coming closer. And we see throughout Latin America now other countries, such as Peru and Chile and Mexico, are starting to become higher and higher in this list as well. In the US, we have over 100,000 deaths, probably over 105,000. And in New York State, and I understand about half of the 600 people who are attending the virtual conference today are from New York State. So I'll disproportionately talk a bit about our state of New York. About 371,000 cases out of 2.1 million tests for about a 17.6% positivity rate. And in New York State alone, there's been a little over 24,000 deaths. On the next slide, we can see that, of course, these cases are not equally distributed across the state of New York. We see in New York City and Long Island and Westchester County a very disproportionate impact, and then some of the more urban areas like Albany, Buffalo, and so on throughout the state as well. And on the next slide, I just wanted to take a moment to say that of the statistics that I've been talking about, every single statistic represents someone, their family, and their community. And here are a number of people who have passed from COVID-19. And these slides with the blue background are slides that Governor Cuomo has used in his press conferences in the past. And the governor highlighted the fact that many of the persons who had passed from COVID-19 were persons of color. And you can see also by the uniforms that many are persons who were first responders and essential workers, people who were driving buses, or people who were working in transportation, or people who were in the healthcare industry, or people who are police officers or firefighters. And so I think that we have to think carefully that every statistic we talk about reflects a person, and disproportionately a person of color. On the next slide, we see that one of the things that we've tried to do throughout this epidemic is to what has been called flatten the curve, that without doing things like asking people to shelter in home, to work from their homes if they can, is that we wanted to try and get the number of cases spread out lower over time so that it didn't exceed the healthcare system capacity. And I think that there's been some success in doing this. On the next slide, what we'll see is that in New York, there's really a big attention to building extra hospital capacity. We were seeing in the early part of the epidemic that hospitals, especially in New York City, were being strained to the breaking point, and they needed more equipment, they needed more tests, they needed more ventilators, and so on. And so in the Javits Center, there was a temporary hospital set up. The U.S. naval ship Comfort came and docked. And all of that was to create excess hospital capacity. And on the next slide, though, we see that thankfully, by trying to flatten the curve, we didn't need as much capacity as we feared we might in New York State. Some of the projections, some of the mathematical models suggested that we might need as many as 120,000 New Yorkers would become infected and hospitalized. And on any one given day, the high point was just under 20,000 persons. That meant there were 100,000 less persons per day hospitalized because of the efforts that everyone took collectively. And that's a function of what government did, but also what private sector did and what individuals and communities did to take a lot of steps. And on the next slide, we see, I think, another reassuring look at where we're at in New York State. In blue is the number of tests per day. And in yellow is the number of people who tested positive per day. And of course, what you really want to see is the number of people testing positive to go down over time and the number of tests to remain high, because you don't want to have the number of cases go down and the number of tests to go down at the same time. You want to keep looking. You want to keep being vigilant to try and find the cases out there. And that's exactly what we're starting to see now in New York State, that the number of tests are high and getting higher and staying at that level, and the number of cases are going down. So this is one reassuring sign. But on the next slide, we'll see that some of the health disparities that I alluded to earlier are quite striking in the state. This is data from the great website called COVID-19 tracker.health.ny.gov. And it's a New York State website for data. And you can see here, if you take the age-adjusted death rate per 100,000 persons, so this is taking fatality and adjusting for population size, that for Latinx community, we're talking 98.2 per 100,000 population. For Black, a little over 100, compared to white, about 26. And for Asian American, about 58. And so I think this slide is the first of several that I'll show that really show the tremendous impact on communities of color, especially Black and Latinx communities. On the next slide, we'll see further information about this. So a few weeks ago, Governor Cuomo in one of his press conferences used this slide and pointed out that we were seeing, and this was actually, I think, the first slide that he used, that really showed some of the earliest indications of these tremendous disparities. These are fatality statistics here, and he broke it out by New York City and New York State, exclusive of New York City. And you can see by population how much difference there is for communities of color in terms of the death statistics and the size of the population. So for instance, in New York City, for Latinx communities, 34% of deaths, 29% of the population. And in the state outside of New York City, 14% of deaths, 11% of the population. And we see similar disparities in African American communities. On the next slide, I wanted to mention that also at that same press conference, Governor Cuomo asked the president of our State University of New York, the University at Albany campus, our president, Dr. Avedon Rodriguez, who's done work in disaster response for his whole career and has worked a great deal on health disparities. The governor asked Dr. Rodriguez, the New York State Department of Health, Northwell Health, and other partners to take on some work related to trying to address these health disparities. And in the next slide, I just wanted to highlight in that vein a paper that we have just come out with in medRxiv, which is a preprint server. This paper is also under review at a journal as well, at a peer-reviewed journal. And this paper looked at cumulative incidence, or number of people who have been experienced SARS-CoV-2 infection through the end of March. And actually, this was an antibody serosurvey study. And later in April, we looked at over 15,100 persons who were in grocery stores. So even while we were shut down, many people, of course, needed to go to grocery stores. If there was one place we had to go, probably it was grocery stores and for a large part. And this looked at finger prick tests for dried blood spot, and then could examine whether or not people had antibodies to SARS-CoV-2. And on the next slide, I want to just spend a moment on this particular slide because I think it really makes an important point about health disparities. This is just a table from that paper that I just gave the reference to. And in this study, again, we looked at 15,101 persons to examine for antibodies, and 2,700 or so of the tests were among persons who were Hispanic or Latino. 757 persons of that 2,735 tested positive for antibodies. So that's 25.8%. If we just weight by demographics. But we can also make some adjustments for the performance of the test. And this was a very good antibody test that was developed here in the New York State Department of Health, Wadsworth Labs. But if we adjust for sensitivity and specificity, that means about 29.2% of persons who were Latinx tested positive for antibodies. And we can take these statistics and estimate how many people in the state actually had experienced antibodies. If we do that overall, it's about 2.1 million persons in the state probably had SARS-CoV-2 experience if we extrapolate from our 15,000 persons to the size of the state. And that means that the implication is that for Latinx communities, about 775,000 persons probably had SARS-CoV-2 through the time of this study. And another way of looking at that is of the persons, of the 2.1 million persons who probably had antibodies at that time, about 36.6% were Latinx. And I think that's really important because if we keep in mind that we're still comparing that to about 19% of the population in New York State overall, that's Latinx, there's a tremendous disparity, and there's a tremendous disparity for African Americans, maybe even more pronounced for Latina communities. And I just wanted to highlight that because I think we have been looking so far in this epidemic a lot at fatality statistics. This paper lets us look closer to the front end of the epidemic to look at what do we see in terms of health disparities in the fraction of persons who are experiencing SARS-CoV-2 infection. So on the next slide, I'll turn very quickly to a few more points before I wrap up, talking about what tools do we have. So it's one thing to identify health disparities, but what tools do we have to build health equity? Well, we have tests now. We have diagnostic and antibody tests. But they were a bit slow to roll out in the United States, so we were a little bit behind and are now catching up. With regard to treatments, we still don't have a treatment, of course, but some candidate treatments like remdesivir and others have been examined at New York State Department of Health in partnership with UAlbany recently published a paper in Journal of American Medical Association looking at hydroxychloroquine and azithromycin. So we don't still yet really have a treatment. We have candidates that people are examining. And also with regard to vaccines, we're probably still several months to a year and a half, maybe more, away from having a vaccine. So the tools that we have available to us on the next slide are some of the things that we've all been practicing over the last few weeks, months, like individual behavior change, hand washing, not going to work if you're sick, wearing a mask. And I think now at the beginning of this epidemic, there wasn't as much a focus on wearing masks as there is now. I think people are recognizing that if you have asymptomatic case of SARS-CoV-2, that you might be transmitting to someone else, even if you're asymptomatic. And that if you wear a mask, it can help avoid that transmission. And so wearing a mask is not only for ourselves, it's for all of us in community, and it's for us as a way to show respect and protect each other. And so I think that's really important as well, too. On the next slide, we see that another tool that we've all had is physical distancing. And I like to say physical distancing rather than social distancing, because I think in this difficult and challenging time, we really have to find ways to become more socially connected even while we're physically apart. this conference is such a good example. Over 600 people are now socially connected today, addressing the issues that are in front of us in this conference, but we're all apart. We're all in different parts of the state and around the world, actually. And this picture I chose to use here is an older gentleman who was celebrating his 67th wedding anniversary and wanted to greet his spouse who was in a nursing home and had to stay outside and bring balloons and this big sign. And it just shows how creative we've all had to become over the last several weeks in order to stay connected to each other, even if we're physically apart. And on the next slide, just to say, I know in New York State and in many of the states that you come from or other territories or other countries, that many have taken steps to pause or shut down. In New York State, this has really meant several weeks of shutting down, but that's beginning to change now. Things like businesses and schools. At our university, we've been teaching online for several weeks now. All of these steps have been taken, and we all know and have experienced them firsthand, so I don't need to go through them. But on the next slide, I would say we're now kind of reopening. So the federal government has started to give some criteria about what are the things we need to be able to do in order to move forward. So they've given us some criteria that things like in each jurisdiction, there should be a testing and contact tracing program in place. The healthcare system should have surge capacity. So if there are many cases that come forward, the healthcare system can handle it. And each jurisdiction needs to have a plan in place for how they're going to address it. And on the next slide, the federal government's also asked individuals to play a role, do all of the kinds of things that have been asked, things like hand washing and avoiding touching your face, all of the basic things that we've all been doing. But on the next slide, the federal government's really asking employers as well too, whether those employers are businesses or community-based organizations, in order to take some steps. So we can go to the next slide that says employers as well. Thank you. And the businesses are being asked to do things like screen employees for their temperature, for their symptoms, disinfecting the workplace, helping people to get tests for COVID-19, and to even do things like contact tracing in the workforce. So these, I think, are really important challenges. We've been talking a lot to businesses lately and hearing about what their challenges are. And I know those of you who are directing and working at community-based organizations, health departments, and other kinds of businesses are experiencing these challenges firsthand. We want the workforce to be safe and protected, but it creates really novel challenges for everyone to address. And on the next slide, I'll just make a couple of last points as we start to wrap up here, is that in New York State, there's really been kind of a philosophy of thinking about risk versus reward. And that is asking, is a business or an industry more essential or less essential? And in that operation of that business or industry, is there a low infection risk or a higher infection risk? And that we should start with things that are in the green, move to things that are in the yellow, and then finally move to things that are in the red. And on the next slide, we see that in New York State, there's been a dashboard that's been put together. And I'm so glad in the chat, people asked for the slides. And Guillermo, thank you for offering those. We'd be delighted to share those. Thank you. That's great. It is in New York State, by each of the regions of the state, there's been 7 metrics that have been monitored, things related to testing and contact tracing, hospital capacity, and so on. And your region can't open until you meet all 7 of these metrics. And even then you have to move through successively more open phases. And now some areas are in phase 1, some are in phase 2, and New York City will probably move to phase 1, as I understand it, starting next Monday. So it's taken longer, given that New York City was really such an epicenter of the epidemic, to be ready to move through these metrics to begin to open next week. And on the next slide, we see a different kind of dashboard even yet. And this is meant to be an early warning system. So if you open up in your jurisdiction and you start to, you want to be able, of course, to monitor to see what's happening. Are things staying okay, or are things starting to get worse? Do you start to see more cases or more hospitalizations coming forward? And I think this kind of dashboard is really critical because we want to keep in mind that we want to move forward. We need to reopen as a society, but we need to do so carefully. And it may very well be the case that we open and then have to reclose. For instance, recently a very large US automaker opened for about 2 days and then found several cases and they had to close down again. And I think it may be the case as we move forward that it's not just entirely linear. We may open for a while and then have to reclose a bit and then back and forth as we address different waves. We'll see how it all turns out, but this kind of early warning system I think is really important because it gives us a sense of how we're doing. And on the next slide, we see that in New York State, also besides looking at these dashboards, there's been a sense that this is an opportunity to reimagine what we want the state to look like. What should telemedicine look like? Whether it's for COVID-19 or HIV or STIs or other areas, more and more people have been using telemedicine during this time. Are there lessons that we can learn? Are there things that we want to do more of based on what has happened during COVID-19? So I think it's also a time for kind of reimagining society as well, too. And the next two slides, I just have to take a second. I'm very proud of our school, I have to say, because we work very closely with the New York State Department of Health. And we have amazing students and faculty who work very much on the front lines of public health in partnership with our colleagues and friends at DOH. And this is just one of our students who was working on contact tracing issues. He's one of many students who worked on contact tracing, epidemiological analyses, writing up papers quickly, making phone calls, all different kinds of activities that were done. And some of it was as paid staff and some of it was just voluntary. So I just have to take a moment to brag on the school, if you'll indulge me, to say that we really value this partnership with New York State Department of Health. And I think our students have really been very much on the front lines. On the next slide, I will say too, we've tried to make sure we've communicated the things that we're doing, not only in academic journals, but with the media as well, from local media like the Times Union paper through national outlets like CNN and Politico and Stat News, because I think it's really important that we have a dialogue nationally as well about how we're doing, how we're reopening, what might come next, and also that we address health disparities and to have that dialogue additionally. So in my last two slides, then I will just say that I think it's important to highlight social issues in COVID-19. When we say to people, you should self-quarantine, I think that implies that you have a home in which you can self-quarantine. If we say stock up on supplies for a couple of weeks, don't go to the grocery store quite as often, it implies you have the resources to do so. If we say stay at home if you're ill, it implies that you have paid sick leave or you can afford to miss the pay. Or if we say don't come to school, it implies that you have somewhere else to go and other sources of food to eat. And so I think it's important for reasons of social justice, and also because any of us is only as well as are the rest of us. We have to find ways that we can take these key measures in our community. And further, we have to fight stigma wherever we find it around COVID-19. This has been a very stigmatized disease. We saw this early on where people were ascribing nationalities to the disease. And just like we fight stigma in HIV and other areas, we must fight COVID-19 related stigma. And on my last slide, I will just say that I think when we started talking about this at the end of February, I would speak of that at COVID-19 at that time as a hurricane watch instead of a hurricane warning. And that at that time, it was time to be in a watch phase and get ready. But now, of course, the hurricane is with us here. The question is, has the eye of the hurricane passed over? And if so, how far away is the eye? Which way will it drift? And is it safe for us to, in a hurricane, we'd say go back home. Now we would say go back out to places of work and schools and so on. And I think that Dr. Tony Fauci at NIH has often been quoted as saying that now's the time for all hands on deck, because when we look at how this epidemic unfolds, really every day counts. A delay of a week of taking some action can make a huge difference for thousands of people's lives. And on March 31st, Dr. Fauci said that while we have to prepare that we might have this summer as many as 100,000 persons, maybe more, and already we're at 105,000 persons, we shouldn't be prepared to accept it. And I think that's really true. By the end of this summer, we certainly will be well over 105,000 persons who will have died, disproportionately so, in communities of color. And we have to understand that that may be the case, but we don't have to be prepared to accept it. We have to do everything that we can every day. And I think it's really true that every moment matters. We have to save every single life that we possibly can. We have to reduce morbidity to the maximum extent possible. And we have to address social inequities that are evident in this pandemic. And as I end, I'll just ask if you put up the last slide, please. I know that in New York State, there's a number of great resources if you'd like to call for further information. Many of you already have access to these hotlines and websites. And also in a number of different states, territories, and countries, I know you have the analogous kinds of hotlines and resources, but I always kind of end with leaving this slide up because it's one place to start if someone has further questions or reaching out for different kinds of services. So let me end there. And as I understand, we don't have exactly the format for Q&A today, but I would say as you share the slides, I would be happy to engage through the Latino Commission on AIDS with questions that people might have or suggestions or comments that you have. So we'll find a way to have a virtual dialogue. And with that, thank you for having me. Muchísimas gracias. And Guillermo, I'll turn it back to you.
Thank you, Dr. Holtgrave. We're so grateful with your, again, your leadership, you know, the school also of the University of Albany playing a key role. Please send our regards to the entire staff of the School of Public Health. And we will probably do something very soon just about COVID, but it was very important for us to be in tune to give the context of the conversation that will be in the next set of panelists. Thank you so much. Well, continue here. Thank you again for the translation. I know that this is the first time that we're doing this. Bear with us. We are trying to do our very, very best. Let me welcome all of you to Reunión Latina Virtual Training Institute. I know that we have people from Puerto Rico, Canada, Florida, New York, People's Republic of Buffalo, New Jersey, Maryland, Texas, Colorado, and many, many other places. The 600 folks that have registered are between today, tomorrow, and Friday from 1 to 3 o'clock Eastern Standard Time. It's amazing that we are coming together and connecting in this space. I'm Guillermo Chacon. I work for the Latino Commission on AIDS, and we will be right now basically presenting to giving welcome remarks. I opened before Dr. Holtgrave give his quick update about COVID. I also acknowledge that the nation is bleeding. You know, institutional racism, police brutality are real, especially, you know, among our Blacks, African American brothers and sisters, and was acknowledged also at the beginning that our communities, especially communities of color, but in underlined, you know, African American Black folks has been heavily impacted, and we want to acknowledge not only, you know, the family and send our condolences to the George Floyd family, but also to Breonna Taylor, you know, to Alma Alberry, Sean Reed, you know, Tony McDade, and other African Americans that has been murdered by most of them by police brutality. And we want to remind ourselves that we need to also fight against institutional racism and zero tolerance to any type of situation that will trigger social unrest that we have been facing right now. With that, I also want to recognize that Luciano Reverte has been doing an amazing job. Daniel Ravelo, Rosy Mota, Dr. Julio A. Roland Mendez has been the team that has been putting this together, handling registration and all of that. And again, we want to acknowledge that this space belongs to all of us. And I'm proud to welcome Betsy Morales, who will be also sharing welcome remarks to all of you. You want to unmute, Betsy?
Okay, here we go. Good afternoon, everyone. Thank you, Guillermo. Thank you for the introduction. Welcome to everyone to Reunión Latina year 25. And while it's not the best circumstance, and while I for sure miss being in the presence of my extremely talented colleagues, at least we have the opportunity to continue doing our work. The COVID-19 pandemic and now the current civil unrest has disrupted how we do our work. And many of us are having to learn new technology, create new systems and protocols. But in the end, we're able to take innovation and put it to use and continue to do what we do best. And that is what I would like for everyone to think about today and in the next 2 days of this training institute. It's your work. What do you do every day in this field, your mission, and that's what is causing change in an individual's life and even saving lives, and change that is for the long run. And we have to think about how we adapt in these disruptive times. So we are living in a difficult time, but we cannot forget that those that came before us also lived difficult times, whether through civil rights movements, Stonewall, the AIDS crisis, women's liberation movement. So many of us have fought a good fight and continue to do so. So we must use all the tools at our disposal to address the impact that diseases, pandemics, epidemics, racism, prejudice, discrimination, stigma, homophobia, transphobia, all of that, the intolerance and the impact that they have on the well-being of our community and our people. And one of the greatest tools that we have is collaboration and unity. We ought to be working together and joining forces to go beyond ETE 2020. We all have our strengths. We can share those and create efficient and stronger movements. Hispanic Federation, Latino Commission on AIDS, the AIDS Institute, many of the agencies represented here today have resources that can be tapped into, so please use them. The first time that I remember that I attended Reunión Latina, not sure, it may have been maybe 2004. I know I look young, I know, but I guess I'm aging myself, but it's all good. With age comes wisdom. But after that, I remember I attended and I, for many years after that, attended and coordinated and participated and even presented and at many more of Reunión Latina. And the information and the knowledge and the tools and the plans of action have been essential to my work in the field of public health. So let's take advantage of this space. Sorry, no dancing shoes required this year, but we have the digital space which we can use to amplify our message, to encourage behavior change, and to foster the spirit of collaboration. I encourage you to take notes these next couple days, to participate, to ask questions, and take those tools that you receive and the knowledge that you gain, and not just implement it, but run with it. Be creative and innovative, and ensure that while you cannot walk into your agencies at the moment, you can still focus on your mission, whether through direct services or advocacy. Focus on the mission. And just how important it's important for us to advocate and exercise for our civic duty, it's important to ensure that we are counted. So my plug, thank you all for those that have completed the census. As many of you know, census data will determine how the federal government allocates funds to our public hospitals and programs like Medicaid, Medicare. So it's not too late. I'm making a call to action to encourage everyone to get counted. And make sure that we get the resources necessary to focus on our mission. Thank you so much for listening, and please enjoy the Training Institute.
Thank you, Betsy. We appreciate your remarks. You're a partner. And again, one thing that I can remind all of us is that you mentioned about the power of coming together, partnerships and sponsors and leaders. In that note, we want to show a brief, I think 1-minute video of one of our sponsors. Are we ready, folks? Yes.
It's time to step up, prep up.
Step up, prep up.
To help keep you free from the risk of HIV. From the makers of Truvada, a new PrEP option. Descovy for PrEP, a once-daily prescription medicine that helps lower the chances of getting HIV through sex. It's not for everyone. Descovy for PrEP has not been studied in people assigned female at birth. Talk to your doctor to find out if it's right for you.
Step up for health and body.
Prep up for your one and only love, or many loves. For kings, this queen, and you royals in between. For my now,
our now,
and my future. Our future.
Step up, prep up. Discovery is the newest way to prep. Discovery does not prevent other sexually transmitted infections, so it's important to use safer sex practices and get tested regularly. You must be HIV negative to take Discovery for PrEP, so you need to get tested for HIV immediately before and at least every 3 months while taking it. If you think you were exposed to HIV or have flu-like symptoms, tell your doctor right away. They may check to confirm you are still HIV negative. Serious side effects can occur, including kidney problems and kidney failure. Rare life-threatening side effects include a buildup of lactic acid and liver problems. The most common side effect was diarrhea. Tell your doctor about all the medicines and supplements you take, or if you have kidney or liver problems, including hepatitis. If you have hepatitis B, do not stop taking Discovery without talking to your doctor. Ask your doctor about your risk of HIV, and if Discovery for PrEP is right for you.
Words are loud, but actions are louder.
Step up.
Prep up.
With Discovery for PrEP.
Get help paying for Discovery for PrEP. Learn more at stepupprepup.com.
Perfect. Thank you. Thank you, control panel, for sharing that important message, and remind us that as equal that we need to advocate for people living with HIV to ensure access to treatment and cultural sensitive care in order to reach, to be undetectable, that is crucial to be untransmittable. We also need to do our very best to address with prevention and PrEP. We know that it's an important tool, among others, to ensure that our communities stay free of HIV. But again, always remember that, this space belongs to all of us. And Reunión Latina, as this year is virtual, as Betsy was mentioning, and Dr. Holtgrave was reminding us that we are, dealing with this giant pandemic. But under that giant pandemic is all these epidemics. And in order to put it in context, we have a powerful panel lineup for all of you. The panelists will do a brief presentation, the three of them, and then we're gonna open it for questions. You need to use the Q&A in the bottom of your screen. Place a question and I will be communicating those questions to the panelists. And then we will go all the way to date until like close to 3 o'clock or by 3 o'clock. And then we will regroup tomorrow again and then Friday. I'm so honored to introduce a very important partner, a very important and close colleague who we work in so many levels. Also, she just finished, and continue to support NASTA at the national level. That's the National Association of STD/AIDS Directors. And I truly believe that we are also very, very blessed to have tremendous leaders in public health. And by the way, not only her role as a director of the New York State AIDS Institute, who have a tremendous record and is a truly a model to follow, has been also a leader in supporting other health departments throughout the US and Puerto Rico, and in some occasions, even outside the United States, because of the comprehensive approach, not only by Joanne Moore, who's the director, but also, the health commissioner at the state level, and also our governor and legislator. We're very blessed and happy to introduce Joanne. You are among friends and family, Joanne. Thank you for making the time to join us.
Absolutely. First of all, thank you, Guillermo, for your partnership, for your friendship, for all the work that is done by the Latino Commission. And thank you for making this available to everyone virtually. I know that in this time of transition, starting with the conversation around COVID, many of us, including myself, as was said earlier, had to learn how to adapt very quickly, become comfortable with Zoom. I'm not 100%, I'm still comfortable with that video when I see the images, but I'm getting better with that. So thank you. And thank you for allowing me the opportunity to join all of you today. I am blessed because every year I have the invitation to come and talk with you, and so I'm grateful for that. And so this year, just as I have in past years, my intention is really to be able to provide you with an update as it relates to the impact of HIV, the outcomes of ending the epidemic, but in particular for us to focus on the Hispanic and Latino community as far as where we are seeing the gains, where we continue to see the challenges, and most importantly, where we have the opportunities for us to continue to partner and work together as we move ahead. That being said, before I begin the formal presentation, I need to take a moment to acknowledge the greatest issue that I see as it relates to the health of all of our state, our communities of color, and the Hispanic community in particular. Health disparities, stigma, discrimination, racism, injustice. And as the world heard the pleas of George Floyd, let us be reminded of our responsibility and the responsibility that we each own in working for justice, addressing systemic racism, and working towards equity. Thank you. Next slide. So, the images that you see here are a collapsed image, if you will, as far as the state response to COVID-19. Certainly, COVID-19 has impacted New York State in greater a way than I and many of you that are listening have ever experienced. Now, I think some of us that are participating today will look at the comparison between what we are experiencing with COVID and what we experienced some 30 plus years ago related to HIV. What's interesting to me and what's so essential is that if you think about what it is that what was priority in leading us towards moving away from HIV being a death sentence to a place where today we stand talking about ending the epidemic and actually achieving many of the milestones towards ending the epidemic, is community leadership. So what we know is that when we are faced with crisis, first of all, this community is extremely resilient. Second of all, we have to make sure that we take the lessons that we learn. For those of us who have had the lessons, who have had the experience, and have been part of the important group of leaders that have built our HIV continuum, what you know is that we have to do the same as it relates to COVID. And what you know is that some of the areas of focus that I started out with are key in order for us to respond, because we know that even in the conversation of COVID, we have seen the issues and experiences of stigma and discrimination. We have seen the challenges of being able to place access to testing and screening in areas where all individuals and individuals of color are able to actually be able to access that. So there are a lot of questions. And I think some of the questions that I ask as we look at this new pandemic, this novel virus, is are we applying the lessons that we have learned? Are we gaining further insight as providers and as community leaders based on what we already are seeing as far as the ongoing needs of social determinants and our response? How are we working to preserve our own selves as we move forward in a response? And so once again, what I want to say is that if not for community leadership, the response that we've seen for COVID and the response that we historically and continue to see related to HIV would not be the same. We would not have the achievements that we've already seen in the last few months. While for some of us, it feels like forever, the reality is we are talking weeks that we have been living in the midst of COVID. And so I applaud each and every one of you for continuing to lead, for having the voice of and being the advocate for those who do not have that opportunity, and working to prioritize the needs of individuals who remain at greatest risk related to COVID and related to HIV. Next slide. So, the images that you see here continue to look at our response. And one of the things that I'm just continue to marvel at is how anyone might be surprised that in the face of COVID, we continue to see health disparities. I can't imagine that we would never not see health disparities, because the reality is those disparities were here prior to the appearance of COVID. So if we did not have the steps taken to resolve the social determinants of health that remain absent to so many of our communities, why would we expect that communities of color would not be disproportionately impacted. So I think what's really important, if you think about New York State's plan to end the epidemic, we have to be clear that it is not demographics of race or ethnicity that places individuals at risk. What it is are the contextual factors of poor healthcare, poverty, inequality, and geographic disadvantages. And as long as we are not focused on our response in those areas, we will continue to see the disparities that we most recently have experienced in the COVID response. Next slide. So what are we doing? I mean, certainly for as long as we have had the response to HIV, and certainly more so even exemplified under ending the epidemic, we have looked for those opportunities in which we can achieve health equity and taken the steps to meaningful, intentional, purposeful steps in order for us to be able to respond to those identified areas that need a greater response from us and greater resources in order for us to build. The images that you see here are examples from our partners here at the Latino Commission on AIDS as far as the priority of health equity. Some of the steps that we are taking in the Department of Health, including the development of a health equity coordinator so that we can prioritize our work and work within the teams that we have, and making sure that we continue to stay in this conversation and prioritize it no matter what part of our response we are talking about. Health equity does not stand in and of itself, but what it does is act as a foundation to every single step that we take in any public health response. Next slide. So here what you see specific to individuals who identify as Hispanic or Latinx is the cascade. So you're familiar with this visual. And we show the estimated number of individuals who are living with HIV, or assumed to be. We show the individuals who have been diagnosed, about 3,600. And what that tells us is that if 3,600 individuals have been diagnosed, yet we estimate 4,200, we have a number of people who are still unaware of their status. When we talk about individual access to care, certainly that number has continued to improve, with 85% of individuals who are living with diagnosed HIV engaged in care, and 76% of individuals virally suppressed. And I'll talk a bit more about the importance of that. Next slide. Here, where we look at some of the demographics as it relates to individuals who identify as being Hispanic, what we know is that individuals who identify as being Hispanic ranked second in the number of new HIV diagnoses in 2018. If we look at the census, we estimate about 20% of the New York State population are made up of individuals who identify as Hispanic, yet still in 2018, Hispanic individuals made up 36% of all new diagnoses. 80% of those individuals who were newly diagnosed in 2018 resided in New York City. And females represented 16%, individuals who at the time of birth were identified as female, 16% of new diagnoses. 17%, and this number is key, of the new diagnoses in 2018 were individuals under the age of 25. So that speaks to access to education, awareness, and the opportunity for us to continue to expand education and evidence-based science among young people. Of individuals who identified as transgender, 42% of transgender individuals were diagnosed since 2010. And if we go to the next slide, what we will find is that 42% of individuals who identify as transgender and diagnosed identified as Hispanic. Transgender women accounted for 86% of all the diagnoses, and 91% of individuals who identify as transgender reported sexual risk as a route of transmission. 73% of the new diagnoses were between the ages of 13 to 34. And again, 42% of individuals who identify as transgender, newly diagnosed from the time of 2018 to 2018 cumulative data, included a representation of 42% of all diagnoses. Next slide. So, as it relates to STIs, what we know is that 25,000 individuals who identified as Hispanic were diagnosed with an STI in New York State. This is looking at 2018 data. 57% of those individuals were under the age of 26. However, the good news is that the treatment rates for individuals were well above 90%. So, what we have to focus on in this example is prevention. So if we can move to a place where we can decrease the number of individuals who are ever even diagnosed, then we're on the right track. But considering the number of people diagnosed, 90% of individuals receiving treatment indicates that certainly as it relates to treatment access, the placement of treatment sites, and our increased ability to provide access to self-testing has proven to be effective. The next slide looks a lot like this slide, except we wanted to provide you with 2019 data. I want to make the point that this only reflects New York State. It does not include New York City. And so for 2019, outside of New York City, an estimated 7,900 individuals who identified as Hispanic were diagnosed. 63% of those individuals were younger than 26 years old. And this is important to note, gonorrhea and chlamydia, among individuals who identified as Hispanic, those individuals were 2 times more likely to be impacted by gonorrhea and chlamydia, and 3 times more likely to be impacted by syphilis, as compared to white, non-Hispanic individuals. The good news again, continuing in 2019, over 90% of individuals received treatment. Next slide. Many of you are familiar with New York Cures Hep C. You'll remember that about 2 years ago, the governor announced that New York State was in a position to look at prioritizing the elimination of hepatitis C. Since that time, we were allotted an additional $5 million, and that money really was prioritized to implement hepatitis C testing and screening within our criminal justice initiative. We were able to add 7 new patient navigation programs within drug user health hubs, which, if you're not familiar with the drug user health hubs, are hubs that historically were known as syringe exchange programs and have grown to expand in their access to healthcare and partnership in the community. And we also implemented 3 new innovative hepatitis C care and treatment models that specifically prioritize individuals who inject drugs, while launching a campaign and strengthening our ability to receive and intentionally utilize surveillance data. Next slide. Here you have examples of many of the funded initiatives across New York State that are intended to prioritize the needs and provide access to resources as well as care for individuals of the Hispanic and Latino communities. Our sexual health Spanish hotline, prevention services, including testing, STI, HCV, PrEP, and PEP. It's significant to be able to call a safe space that is able to provide you with education as well as access to services that are culturally responsive. Certainly, our partners at the Latino Commission on AIDS continue to provide capacity building assistance in multiple ways, providing prioritized services to individuals or men who identify as gay, bisexual, or who have sex with other men. Again, promoting health and wellness, providing TA, which is so significant so that agencies and organizations, community-based organizations, can continue to build their capacity, and looking at the opportunities to provide additional support. If it was not for the partnership of our community-based organizations, as presented here, we would not be in a place where we're able to talk about things like 90% of individuals receiving treatment, the significant reductions that we have seen over the years as it relates to HIV diagnosis, and the ongoing level of support that individuals need. Next slide. Here we have an example of one of the projects that we've worked with in partnership with the community. I know that when you talk about molecular science, it's it can be a very excitable subject. And I know that there are a lot of opinions as to the appropriateness of doing this type of work. What I want to say is that in New York State, the priority around these types of initiatives has been around community partnership and ensuring that individuals have access to the services that they need. So, in addition to the epi-informed partner services aspect of this program, I want to make the point about the benefits of expanding access to HIV testing, of providing greater access to initiatives like HIV home test giveaway, of ensuring a CBO-based social network that provides testing, partnership, and support, and works in collaboration with the partner services team while understanding that the subject matter experts in this discussion and in this project are the community members. And of course, individuals with lived experience. Next slide. Just this is an example as far as the number of individuals who are utilizing our syringe exchange services. Certainly that we know through the time of COVID, where there is a number of precautions that have to take place, including the physical distancing. I prefer physical over social. I think we all need that social interaction. The physical distancing, I understand, as a form of prevention. And our syringe exchange programs across the state have put into place so many innovative ways in which people who are injecting drugs are still able to feel supported, are still able to feel that they have a network, and are able to receive the resources and tools that they need in order to ensure reduced risk. So what we know as it relates to the Hispanic and Latino community is that about 40% of individuals who utilize syringe exchange programs or the drug user health hubs identify as being Hispanic. In New York City, the majority of individuals who are using these programs do identify as being Hispanic or Latino. And the greater portion of individuals identify as being male, 69% as compared to 28% of individuals identifying as female, and 3% of individuals identifying as transgender. Next slide. This image is familiar, I hope, to everyone. U equals U, undetectable equals untransmittable. We have come such a long way. And if you ever need an example about the value of persistence and science and evidence, U equals U is that. The knowledge of knowing that an individual who is suppressed as it relates to HIV and is suppressed and cannot sexually transmit the virus is key. It speaks to adherence to treatment. It speaks to a reduction in stigma, and it speaks to the ability to expand and advance in our prevention options. It also speaks to many of the other services that have been put in place as a result of the advancements in science and biomedical treatment that we have, including the rapid initiation of ARTs, meaning that an individual would be offered the opportunity to begin medication immediately upon diagnosis. What we have found with the implementation of rapid initiation is that individuals are able to achieve a viral, suppress a viral load within under 30 days. And that is significant to the health of the individual and to their partners. Next slide. PrEP, again, another key advancement that we look at. And I think what's key here in these images is recognizing that you have to provide information to individuals in the language in which individuals speak, with the images that identify for the reader. And certainly what we know is that we want to make sure all individuals have an understanding of the benefits of PrEP, as well as PEP, post-exposure prophylaxis, pre-exposure prophylaxis, for the purpose of maintaining an HIV negative status. So what I want to say before going to the final slide is that if you listen to the points that I've made, focus on HIV, focus on STI, focus on hepatitis C, I want the takeaway to be not solely about the prevention of disease, but to focus on sexual health. And that as we continue to promote the value of sexual health to individuals, it will become more routine, more accepted, and more comfortable for us to talk about prevention and care and treatment. The shift from a disease-focused model to a positive frame of sexual health is key. And in particular, if you think about some of the points I made related to age, we have to consider that because we have the opportunity for some of our young people from the very beginning of their discussions around their health to value the inclusion of sexual health as part of their whole being, and to value and accept that in order to be healthy physically, emotionally, mentally, that they have to include sexual health in all of their discussions. Next slide. And so there I am. I want to say thank you to all of you. I want to give my best, of course, to my partner, Guillermo, all my colleagues at the Latino Commission on AIDS, and to all of you who take the time to be a part of these discussions and come into these rooms. Understand the impact that you're having on the lives of other people. Understand that your work is what will get us to a place of justice. And I know that the images and the sounds and the things that we're seeing and hearing right now can be exhausting. Our souls hurt. But know that every time you reach out and connect with another person and provide them with access to the information that we share here today and through the days of this conference, that you are part of the foundation that will get us to a place of justice. Thank you, everyone. Stay well, stay safe, and most of all, stay informed.
Thank you, Joanne. I just want to remind to all of you, I noticed that we have 232 participants in the next 3 days. The total will be like 600 people. And again, we're right now on the opening of Reunión Latina, the Virtual Training Institute. We just finished with Joanne. Thank you, Joanne, to you, your leadership team and the entire workforce at the Department of Health, ACE Institute, but the entire, healthcare workforce throughout the U.S. The public health is broad, it's those that have been treating folks in the hospitals and the clinics are heroes and heroes, but also, the folks, the researchers, the public health folks that are thinking about how to prevent and contain the spread of HIV, STIs, hepatitis, but now COVID, all of us are together. The essential workers, the people that deliver food, we need to protect those individuals because we are all together. Bear with us, participants, attendees. We just get the statewide perspective from New York. We're going right now to a federal and then a wonderful and important presentation from Dr. Melendez Rivera from Puerto Rico. And then our next speaker that give us a federal perspective also is a tremendous champion, someone that hit the run running, Harold Phillips, Senior HIV Advisor and Chief Operating Officer of Ending the HIV Epidemic by 2030, a plan for America, part of the Office of Infectious Disease and HIV/AIDS policy within Health and Human Services, is here to be the next presenters. Harold, we honor you, we respect you, we admire you for your work, you and your colleagues, and we give you the stage of Reunión Latina Virtual Training Institute. Welcome, you're among friends and colleagues and family.
Thank you, Guillermo. Thank you very much. And thank you to the Latino Commission on AIDS and the Hispanic Federation. I'm extremely pleased to be able to be with you all today as part of this gathering and talk about this important work. Thank you to Joanne for the wonderful work that has been happening in New York State that is also helping to move us forward. Am I sharing my screen, or do you all have them? However you want me to do it, I will do it. Awesome.
We just call for the next slide and we will run it, Farrell.
I will do that. And before I start, I want to share something that I've shared with others yesterday. Yesterday we had the President's AIDS HIV Commission meeting, federal meeting that we have quarterly. to talk about how we are moving forward. Yesterday's meeting focused a lot on COVID-19. And I just want to say a special thank you to those who are representing health departments, community-based organizations who have continued to provide care and treatment and really rise up to be examples of how we reach the community and are passionate about the work that we do. I also want to say to you all, I know that currently our country is going through a lot. We all are experiencing various levels of sorrow, of tragedy, and of frustration. And something that my mother says to me repeatedly throughout this, I just want to share because maybe it will help some of you as well. What she often reminds me is that we are people of color. And as people of color in this country, we have gone through many, many hard times, from some of our ancestors who endured slavery, oppression, discrimination, medical mistrust, racism, brutality in some cases, and even murder. And as people of color, our ancestors went through it. They were strong and they were resilient people, and that's our makeup. And as we go through this tough time in our country, we need to call upon that resilience to make it through this as well. I share that with you all because even though right now it is the African-American community that is in the forefront, it doesn't go unnoticed that our Latin and Hispanic brothers and sisters also face some of these same challenges as well. And so we are all this together, and this is not a time for us to be divided. We need to be united as we come together to address some of these and continue to work to get to a better place in this country. I also want to share that as the Chief Operating Officer for the Ending the HIV Epidemic in the Office of Infectious Disease Policy with the HHS Office of the Assistant Secretary. Back in January, I had the privilege of being in Riverside, California, and San Bernardino. And there I met with members of the Latin and Hispanic community and talked about HIV and STIs, difficulties that they have in navigating the systems. And I'm going to share with you just the stories of a few individuals that kind of set the framework and the context for what I'm going to talk about we need to accomplish on the national level. And I think Joanne did a great job of talking about sort of New York State and how they are approaching sexual health, really breaking down some of the silos and looking to address both HIV, viral hepatitis, and STIs, which continue to plague the Latin and Hispanic community. First, I met a gay gentleman from Central America who English was not his first language. He had tested positive in the summer. He didn't have a promotor to help him navigate the system. He was figuring out how to navigate the system because he had heard that there were HIV services that were available to those who were undocumented. I assured him that he had no fear in talking to me, that I was really interested in hearing his story. And he talked about how his English wasn't very good and that he was continuing to try to teach himself English, but he was doing all of this with me in English and telling me the story of how he didn't know where to go to get services. He had heard that services were available. He needed to be connected. He had challenges around housing and food insecurity, but he was able to find an agency, find a case manager. And when I met him in January, he had achieved an undetectable viral load and was connected to care and committed to making his medical appointments and to continuing to take his medication in hopes that he could continue and find and live his American dream here. I also, at that same meeting, met a woman who had lost her husband. He had a number of underlying health conditions, but no one had ever given him an HIV test until about 2 months before he died. They later gave her an HIV test and found out that she was HIV positive. She was in this meeting for the first time with other people who were HIV positive, and she broke down and cried. She still felt like her life was over. And she asked, where are our churches in all of this? At that meeting, meeting folks that were HIV positive, some of them had been longtime survivors. They took her in their arms, reassured her in Spanish that everything was going to be okay and that she was among friends and they were going to help her. These are just two examples of where our system needs to do better. And that these are situations in 2020 that remind me of situations that we have been in the past, back in the 90s and the 80s, where the system was not working for the Latin and Hispanic community the way it should. So with that, I'm going to talk about the plan to end the HIV epidemic. I'm going to share some examples of some of the success stories, but I want us to keep in mind the systems that we have now, we need to be able to do better. We can do better. We have a lot of success stories and we need to build on those. I'm hoping that by 2025 and 2030, the stories that I heard in Riverside and San Bernardino will be less. And that I'm hoping to be able at some point to get back to those communities and meet with those individuals. And hopefully they can tell me much better stories of their overall success. So next slide. Let's talk about what I'm going to cover. The Ending the HIV Epidemic overview. I'm going to give you an update of where we are right now with the initiative. I'm going to talk some about COVID-19 and HIV and what we see as new service delivery models that are evolving and changing. And as we think about sort of the overall Latinx health agenda, how we put these issues forward and how we think about these models and how they may need to shift for some of our communities, and that we need to ensure that these services are culturally and linguistically appropriate for the populations that we truly need to reach if we're going to end the HIV epidemic. Next slide. For those of you who don't know, the Ending the HIV Epidemic Initiative, Plan for America, was announced in February of 2019. In 2020, we've still been rolling out funding for the initiative that I'll talk about. But the initiative has a goal of 75% reduction in new HIV transmissions within the next 5 years and a 90% reduction in 10 years. It focuses on what we call the 4 pillars to achieve those goals. Diagnose all people with HIV as early as possible, treating them, and then prevention, preventing new HIV transmissions by using PrEP and PEP and syringe services, exchange programs, as well as treating those with HIV, which also means connecting them to care within 30 days of diagnosis, that those who are out of care, that we take the time to find them and relink them to care. And then Joanne talked a little bit about sort of response, using molecular surveillance to respond to outbreaks and ensure that communities have access to the prevention and treatment services that are needed when outbreaks occur. Next slide. The initiative itself focuses on what we call the phase 1 locations or jurisdictions. These are the 48 counties, including DC and San Juan, that account for 50% of the new diagnoses in this country. It also includes 7 states with substantial rural HIV burden. These are the phase 1 jurisdictions, as we call them. And so if we concentrate some of the efforts in these jurisdictions, many of which I'm glad to see are represented on this virtual meeting today, as you all have said hello to participants and everyone. So it's great to have you all here. These are where we're concentrating some of our efforts in order to end HIV within our country in the next 10 years. Next slide. So, like I said, it was announced in February of 2019. We've been rolling out, and so some of our accomplishments in regions, HHS regions, Health and Human Services regions 4, 6, and 9. That's Atlanta, Dallas, and Los Angeles. There are 2 Commission Corps Public Health Service officers each in those areas that are responsible for the regions, and they are our Ending the HIV Epidemic Initiative leads. I saw Michelle Rosario Sandoval is on the call today. She represents Region 9. And so within those regions, they are responsible, and they have become in many ways my right hand from here in Washington, helping to implement, ask questions, work with the jurisdictions to implement EHE. They've been involved in the planning and also understanding the challenges that the community has as well. We have funded 4 Jumpstart programs in phase 1 jurisdictions. Those are East Baton Rouge, Louisiana, Baltimore, Maryland, the Cherokee Nation, and DeKalb County, Atlanta, to begin programs where we can learn lessons about what it takes to sort of scale up access to HIV testing, prevention services, as well as treatment. Some of the things they have done include starting HIV testing programs in jail settings, working to expand HIV testing in emergency room settings, working to get those who are out of care relinked to care in a number of ways using data to care analysis, as well as technical assistance to providers about how to implement and start PrEP programs in clinics within the Cherokee Nation. All of the phase 1 jurisdictions have developed draft community plans for ending the HIV epidemic, which have been reviewed by CDC, HRSA, and our office at HHS. Funds have been awarded for HIV PrEP initiation, linkage to treatment, engagement, and care through the HRSA Ryan White program in the HIV/AIDS Bureau, as well as the Bureau of Primary Health Care. We have also started at HHS the PrEP medication program that I'll talk about, Ready, Set, PrEP, and how that works to ensure that individuals who are uninsured and at risk are receiving services, PrEP services. Next slide. The awareness campaign known as Ready, Set, PrEP, and I'll show you a little bit about that as we go on. The next thing that will be rolled out is the Ending the HIV Epidemic Initiative Data Analysis and Visualization Dashboard, known as AHEAD. I'll give you some update on that. And we're also working with our federal colleagues because we have learned a lot about the issues regarding housing and access to stable housing and its impact on both prevention and care services. So we're working closely with our partners at HUD around that, as well as working with VA, OMH, OWH, Office of Women's Health, to address some of the needs that we have there as well. We are also exploring future collaborations to be able to deal with some of the policy issues that have crept up as well. They might get in the way of us reaching our EHE goals, so we're trying to work across the federal level on that. And then I'll talk about the whole of society approach and EHE engagement as well. Next slide. As we've rolled all of this out, there have been a number of listening sessions throughout the community, throughout the nation, and we've heard some of these issues that we also need to think about and address. Having access to services, the need for innovation, and think about non-traditional delivery systems, and expanding telemedicine or expanding the use of case management in a variety of ways. The role and the impact of stigma and discrimination, how it impacts outcomes along the continuum, but also how it impacts each of our 4 pillars. The need for more coordination of care, and really thinking about not only coordination of care among our clinical providers, but also coordination that enables us to address the social determinants of health. The need to communication, and the need to focus on scaling up the workforce, both within our public health department, but in our community-based agencies that help people living with HIV, and also helping people of color enter into the clinical workforce as well. Next slide. So the prevention through active engagement, active community engagement, the public health officers that are assigned as helping to be the right arm of the HHS in serving both as public health educators, coordinators, and as communication force multipliers for our messages within the central office here in Washington, D.C. There are great, both passionate individuals and really working to engage the community. And they also serve to make sure that we in Washington are not operating in a bubble where they are bringing to us the concerns of the community that they have heard as well. So for those of you that are in HHS regions 4, 6, and 9, I really encourage you to reach out to our PACE officers and really engage with them, because they take they take it seriously, their responsibility of making sure that your needs and issues are heard by us here in Washington. Next slide. The Ready Set PrEP program, which is the HHS PrEP program that provides medications at no cost for qualifying individuals. I'll talk a little bit about that. We really took the time to make sure that this didn't look like a government campaign, that it was reflective and it could draw in the interest of those individuals that we need to reach with PrEP services. Currently in this country, there's a PrEP divide in that those who could benefit from PrEP, usually people of color, are not accessing the medication or the programs. And so really doing that work and ensuring that we do this campaign the right way. I'm gonna be very excited about when we are able to roll out phase 2 of it, which we're gonna use real individuals on PrEP, telling their stories, talking about what PrEP really means to them as well. Uh-oh, I lost my headphone. Next slide. So for our program, individuals must test negative, have a valid prescription for PrEP, not have prescription drug coverage, and there's no cost for the medications to the individuals. Some of the clinic costs and labs may depend on the person's income and where they receive their PrEP. In order to access the program, the enrollment page, we've made it easy on the website, getyourprep.com, where you can enroll. Next slide. These are the retail pharmacies that distribute the PrEP medication at no cost. The participating pharmacies also have a mail order option for those who request it. The pharmacies also provide patient counseling and take steps to promote patient adherence. Currently, with this network of pharmacies, we are able to have pharmacies in 26,230 pharmacies across the country, and we continue to work with our partners, our pharmacy partners, on rolling out the program and continue to ensure that there is work that addresses the issues of cultural competency. And many of the communities, especially the Health Mart pharmacies, many of those neighborhood pharmacists come from the community and are able to provide services in Spanish as well. Being in DeKalb, we met with some of them, and it was a very good meeting and talking with them about how they provide services. And many of them also have a history of serving people living with HIV. So making the transition to providing PrEP services, they were excited about being able to do that and use their experience in reaching various groups of people living with HIV to continue providing prevention services. Next slide. The PrEP awareness campaign, we've been working with our folks on this, Bernette Garcia, some of the branding and creation materials. I talked about phase 2, but we're going to be extending the campaign and looking for real people using PrEP to talk about what PrEP has meant for them and what it, and sort of in some ways, some of the freedom from worry that it has given them, and some of the empowerment aspects of PrEP. And so we're going to talk about that as well and use that as part of the approach. There'll be owned media, earned media, shared media on Facebook and Twitter and YouTube, as well as some of our paid media ads moving forward. Next slide. There are fact sheets and posters and information cards, social media toolkits, and shareable graphics that are available in both English and Spanish. We are very happy about that piece of it that allows the materials to be used in that way. They are available for download, so I encourage those of you that are in community studies to definitely go to the website and download those materials. Next slide. I talk about AHEAD, Advanced HIV Epidemic Analysis Dashboard, AHEAD, which is our visualization tool. And it will be a data dashboard that will show the 2017 baseline data that was used to create the EHE initiative and indicator targets for the 6 HIV indicators. And so the public will be able to see our progress as we move toward the goals of the initiative, and hopefully will be a useful tool as we all work together to understand where we are with the HIV epidemic. Next slide. The 6 EHE indicators: incidence, knowledge of status, diagnosis, linkage to HIV medical care, viral suppression, and PrEP coverage. In many of the jurisdictions, this will be the first time that they will be seeing this data and the indicators live. It will be posted for everyone to sort of see where we are and also what we're trying to get to. We hope that it will be useful in both planning, monitoring, and also communicating the importance of HIV as a public health issue to many of the key stakeholders across our country. Next slide. So in terms of federal funding, we started the initiative, like I said, with the Jumpstart sites. We were able to provide $33 million in minority HIV/AIDS funds to begin work in the initiative. In 2020, the allocation of $291 million. And then the president's budget request for 2021 is $716 million. Big jump for EHE. I will say also that EHE remains an administration priority. And that has been communicated to us even through the Assistant Secretary for Health, and as we continue to move this forward. So we are watching very closely the congressional budget process, but this was the president's request for the initiative as we move forward for 2021. Next slide. Many of the funding opportunities already are underway. We talked a little bit about the planning piece. Draft plans were submitted in December 2019. Jurisdictions received feedback on their plans around community engagement and the rest of it in March 2020. The final plans are due back to CDC by December 31st of 2020. Due to COVID-19, the application due date for the implementation of programs, PS 2010, was pushed back to May 1st. And a proposed start date was also shifted to August 1st for 2020 as well. And this will take care of the diagnose and treat pillars and some of the prevent pillars as well through the CDC. Next slide. HRSA was able to make all of its funding awards to those to the Bureau of Primary Health Care, which expands prevention services in over 200 health centers. The provision of PrEP, paying for PrEP navigators, to be able to implement PrEP, strengthening, I think, HIV testing, and some of the lab costs and STIs within health center settings to get folks linked to prevention. Ryan White funding, as well as the technical assistance provider and the systems coordination provider, those funds also went out. And so that was about $70 million of Ryan White funding, Ryan White Parts A and B. That also took place in March, all before we sort of went to COVID. Next slide. So our office, the Office of Infectious Disease Policy also will be funding 9 projects that we hope will give us some more examples and innovative approaches to help end the epidemic. The Centers for Disease Control There will be scaling up HIV prevention in STD specialty clinics through training and technical assistance. Like you heard from Joanne about the importance of STIs, especially gonorrhea, syphilis, and chlamydia. They will also be doing mass mailing of HIV self-tests to transgender women and racial and ethnic minority communities, and seeing and studying how that works and impacts the availability and access to HIV self-testing. So excited about that. First, currently has their grant application on the streets. If you haven't seen this one, about technical assistance and training on stigma and cultural humility, as well as improving care and treatment coordination for Black women with HIV, and also studying different ways to implement rapid ART projects for improved care enhancement in Ryan White settings. So 3 opportunities that are currently on the street. Those applications are due sometime in June. So later this month. Rumor has they're considering perhaps pushing it back, but definitely check the HRSA HAB website for more information on those. We were also excited about being able to fund an Indian Health Service to scale up both universal access to HIV and hepatitis C training, as well as working with pharmacists in Indian Health Country to help them implement PrEP programs, working on reducing new HIV transmission within Indian Country, and a project targeting teens and young adults, continuing funding for that work, where in Indian Health Services, huge disparities that mirror those of other communities of color, especially those focusing on MSM or two-spirited individuals within Native populations. Next slide. HIV and COVID-19. You heard, those of you that were on earlier heard from Dr. Holtgrave some of the implications of COVID-19 and those living with HIV. We have, during this period of time, really worked, I think, to scale up the availability of telehealth services, as well as trying to make sure that the message about the importance of staying in care for those living with HIV, medication adherence, continuing to work to meet and attend clinic visits where clinic visits are still happening, or switching to the telehealth message, but the importance of taking care of oneself if you're living with HIV, and if you are not in care, getting in care. Next slide. So again, it remains an administration priority. Some of the things we've done to sort of help along and through some of this, emphasizing the importance of HIV self-testing, and working with CDC, SAMHSA, HRSA, Bureau of Primary Health Care, which have all provided similar language around the importance of self-testing and the ability of recipients to use grant funds to purchase self-tests. We've also worked with Shore, the maker of the self-test, who has provided a discount to those who are buying in bulk, which has reduced the cost of the test, and that reduced cost will go through the end of September for those who are in that position, either health departments or CBOs who might be looking to use those tests. Next, and we've got some great examples that we've been promoting those in New York, Virginia, and Arizona, and the ESTAMP study of the importance and the efficacy of HIV self-testing. Next slide. PrEP provision, giving social distancing at this point in time, and the reduction in sort of public health services. The CDC Dear Colleague letter, if you haven't seen it, a link to it is provided on the slide, with the slides will be made available. Also switching to multi-month prescriptions, 90-day supply, and ensuring that that is there for patients as an option, so they don't have to travel as much or interact with the pharmacist or their prescriber. And we've also heard about innovative home delivery of syringe services programs, at home and mail order condom distribution that is happening, at home STI provisions. I've even heard of at-home methadone being provided in some cases to ensure that people have access to their behavioral health interventions and keeping them on that path and connected to care. So again, this time calls for us to be extremely innovative in our approach and thinking outside the box. Next slide. Our overall, our federal agencies have worked to create additional flexibilities to allow this to happen. And I think that we'll continue to look for different innovations and things that we can do that sort of relax some of the policies that previously have gotten in the way of us doing this work effectively, just so that we can continue to serve the communities. Next slide. Also, HIV.gov, which is our website, hiv.gov/coronavirus, contains a collection of federal resources for people living with HIV, healthcare providers, for service organizations who work with them, and we continue to update this website with additional resources so that folks will have them. Next slide. Again, some other tools for those to sort of look at. Even our partners at HUD have provided additional guidance because, like was also mentioned, those who are homeless or in congregate living situations have a different set of challenges as a result of all this. So HUD has provided some additional guidance, which some of you may find useful. Next slide. And I think I'm almost done. EHE is a whole of society initiative. And so we need everybody to be involved. Like the woman who asked, where is the church in the Latin community? Important institution. We are working to figure out how to engage churches in this, academic institutions, local health departments, patient advisory groups, nonprofits, the business community, because it's going to take all of us working together. I think during this challenging time, we're seeing that people need not only clinical services, but they're going to need food, transportation, and all of these things that are social determinants of health. We at the federal level can't do it alone. And so we are looking to partner, and we are figuring out how to partner and make them aware of the fact that we can end HIV in this country, and that we have a 5- and 10-year goal, but it's going to take a whole of the society approach. So thank you all for the work you do. Thank you for your interest and for allowing me to speak with you today. Thanks.
Thank you, Harold. Very, very, very kind of you to make the time, and we will, share these slides. Moving along, we're so blessed to have not only a tremendous healthcare provider, a tremendous physician, but also, a leader for us, someone that we respect very, very much, who always seek for advice, Dr. Ivan Melendez Rivera, with Centro, Chief Medical and Operating Officer at Centro Ararat in Puerto Rico. Dr. Melendez Rivera, welcome. You are among friends and family as well.
Okay. Hi, everyone. I don't know if you can see me.
Not yet. You just need to click your camera, because right now,
yeah. Yeah, give me 1 second. I don't know.
I can hear your beautiful voice. And then
okay, thank you.
You just call the slides, Dr. Rivera. And,
okay, stop. No, I have the video. I don't know why I say that stop the video.
We got you.
Okay, you got me perfect. Let me see if I could put this in small size. Can you see me now? Okay, yes, I can see myself. That's good. So good afternoon, everyone. And also thank you, Guillermo, for this kind introduction. For me, really is a pleasure to be here today. And thank you for the opportunity to be part of this opening panel, providing the view, in this case, of the Hispanic issue at the local level. And also to have the opportunity to join here with my friends. Welcome all of you to this reunion. I want to start to acknowledge these are difficult and complicated times. We are standing witness some of the most impassioned pleas for justice that this country has lived through the past 15 years. And every call for justice is its truest essence a call for leadership, a call for responsible leadership, a leadership that set a space at the table, a leadership that listened, a leadership that looked inside itself, a leadership that is fully committed to respond. We are hopeful for leadership that lead with compassion. We are hopeful for leadership with a commitment to introspection and corrective actions. And our job here today and every day after we disconnect from the conference is to be that kind of leader. Because the justice that our fellow citizens are passionately clamoring on the streets of our nation goes beyond the bounds of policies brutality and racial justice. It goes beyond the issues that is truly asking and pushing us to examine all the inequities in our country, in our city, and in our community. I don't want to lose sight of what we are getting here today, but I believe it's important to acknowledge in all the ways in which we must name the inequities and all the ways in which we respond. Today in America, our Latino community is confronting a significant inequity in access to quality, affordable, preventive health care. Health disparities do not only harm the individual and the community that experience them, they hurt the whole nation. The community and the condition of the community where you born, grow, work, live, and age plays a large role in the development of the different health inequalities. It should not surprise us to note that as a community, Latinos endure with higher unemployment rates, low educational level. We have access to less test days than the non-white Hispanic worker. We have higher birth rate, and also our Latino children are disproportionately poor. 1 in every 3 living in poverty, and 2/3 living in low-income households. The community we serve needs better access to nutritious foods, decent housing, safe workplace, and home and workable neighborhood, safe place for physical activity. We also need affordable, reliable public transportation and clean water and clean air. I have been in the medical practice as a family physician in the south of Puerto Rico since 1994. I have served men and women of multiple settings since that moment, including those who are part of the prison system. But in 2001, I have worked nonstop at Central Arad, a community-based non-for-profit primary care organization. Over the last 19 years, our clinic has grown to serve nearly 1,000 persons living with HIV. We have also developed 2 specialized clinic care facilities that I'm very proud of, our translucent clinic and our sexual health clinic. As translucent clinic, we serve over 170 men and women of transgender experience. And our sexual health clinic, we operate the largest PrEP service program in Puerto Rico, providing STI prevention, hepatitis C treatment, and access to PrEP to more than 500 persons. It can feel good looking back and for the last over 20 years and see we have been able to achieve. It's really feel good, pero muy, muy bueno. But it is impossible for us to look what we have been accomplished if we not see all that remains to be done. In Puerto Rico, Central Arad is one of the many non-profit primary care organizations working alongside with many federally qualified health agencies to provide service for HIV population and to prevent others from the exposure of the virus. We operate in large and small cities and towns, in urban and rural settings, committed to reaching and serving the folks we serve wherever they may be. Historically, we serve men and women who acquire the HIV virus through sharing needles, the folks at the epicenters of the HIV epidemic in Puerto Rico. Nearly half of the persons living in Puerto Rico right now with HIV were exposed to the virus in this manner. But today, the rising numbers of persons exposed to HIV in Puerto Rico are men who have sex with men. They are young, they are sexually active, they are mostly ill-informed about HIV and about how to protect themselves from acquiring the virus. Each one of us here today knows the HIV reality and the manifest in our community. We know that the history and the path of the epidemic varied from the island to the mainland, from the countryside to the city, from the east to the west, and from the north to the south. And we are also familiar with the many other health disparities, health risks, and conditions that have a very significant impact in our Latino community. Disparities that which exacerbate other health concerns. Imagine managing a chronic illness like diabetes or asthma becomes so harder when you don't have access to doctor or when the medication you need are too expensive to pay. And through all the challenges are big, we are not without important capability to address them. We know our people, we know our needs, we know what works and we know what really doesn't work. And we are ready to bring all that knowledge and put it on the table here in this meeting as an open dialogue and listen and examine ourselves and respond with passion and respond with compassion. To address these inequities, we can start with the science. We can build our clinical expertise, our access to the therapies of our HIV that we have right now. But that is not enough. It cannot be enough because if it's there, this inequity will not exist. So we are called to the table from each corner, from clinician to non-clinician, treaters and patients, community leaders and allies, educators and advocates. The most important part of ourselves as a healthcare provider is to ensure that there's an effective communication between healthcare professionals and our patients. We must promote a trusting relationship and encourage patients to call and ask for questions. We need to ensure that the communication about health and the impact they have in the different groups of population is frequent, clear, transparent, and especially credible. We are called not only to be there, but at this movement, we are called to not stay still. We are called to insist and insist in our voices to be here, to insist and insist on an adequate resource to support our work, to insist and insist on sustained and ongoing dialogue with those we seek to serve so that change can happen, so that fear can be overcome, so that our community are not seen only for what we need, but they can see us for what we can bring to the table. So that is a dialogue open. That is sincere. That is filled with the passion to overcome what is wrong and with the joy to celebrate what we can achieve. Our Latino community is varied, very, very varied. We come from different places. We face and advocate and fight for the health of our community in many varied ways. And we are creative and we are adaptive. And we blend our cultures, we blend our language, we blend our religions in a myriad of ways. And we get things done. Let me remind you something. We as Hispanic and Latino, no matter all the situation, we know that we have the will, tenemos la voluntad, we have the skill, tenemos las destrezas, we have the courage, tenemos el valor, we have the commitment, y tenemos el compromiso. We have a lot of work to do, and we are going to get it done. Muchas gracias, and keep everyone safe.
Thank you, Dr. Ivan, and thank you to the panelists. We have a little time for Q&A. Question for Joanne. Joanne, is you still with us? Joanne Moore? Maybe not. Okay, yes. I see her that she unmute.
Here
Hey,
I am.
yes. Question for you. I'm gonna ask one question to each of you from the Q&A section. Someone wanna know about your harm reduction programs. Is those people accessing services through your harm reduction programs in your state? If they have any concerns regarding taking PrEP for any interaction for some, something that they might be using?
Sure. So I should say first, I'm not a medical physician, so I'm not offering clinical advice, but actually our syringe exchange programs and drug user health hubs are one of our key partners in promoting and making sure there's access to PrEP. Recognizing that, we want to provide every prevention opportunity to individuals. So there is no interaction that I'm aware of or that has ever been reported to us. What there is the ability to help prevent HIV transmission, as well as provide education and awareness so that individuals can consider what's in their best interest based on their existing lifestyle.
Perfect, thank you. And again, I will echo only that, it's crucial, as you mentioned, that always consult your physician, he or she, to make sure that, you're in sync about your needs. A question for Harold is, what is the, when the new budget, the 21 budget will be approved, and if you feel optimistic about, continue supporting and enhancing this important 10-year initiative.
Sure. I want to thank you for that question. And I also want to go back to the last question as well, in that we have been working with our partners at SAMHSA, and I think I wrote this in the chat box as a response to the question. And I tried to answer as many questions as I could in the chat box, just in case we didn't run out of time, because they are really great questions. Thank you all. Check the SAMHSA website. One of the things that we're doing on the federal level to in the HIV epidemic is expand HIV testing in substance use treatment settings, as well as expand access to PrEP. And like Joanne has said and Guillermo has said, there are no sort of reported cases of interaction between adverse interaction or bad interaction between PrEP medication and what someone else may be taking in terms of substance abuse treatment. And it's actually a strategy that we're working to enhance and scale up across the country. Now I forgot the question. The other question.
Is there optimistic you are?
Budget.
Oh, the budget. Oh my gosh.
The 10-year plan.
I think you are.
I am optimistic, and here's why. There's been great support across the board, both across the political parties and in Congress, for ending the HIV epidemic. The timing, I don't know, in terms of when Congress will get to passing our federal budget for FY21. We need a budget passed before September 30th, or else we might be unemployed, but okay, I'm still at home, by September 30th. So, definitely we all will be watching this process, but I think there's great commitment, and we've got folks who you've seen like Anthony Fauci who've said, we can do this. It's going to take resources, some thought, and engagement with the community to really make it happen.
Thank you, Harold. And for you, Dr. Melendez, a question was, if you could share more or less an estimation, how many people are living right now in the island, living with HIV/AIDS? Because, in the news has been that a lot of people have been leaving the island, but if you can share like a, bulk number or an estimation would be fantastic.
Well, the number right now is close to 18,000 people living with HIV. The exact number is does show up like 2 days ago, but we have more data regarding to that. How many of them have really moved? We don't have the complete data. We are relying on whatever the clinics is provided to us this data, not to me, to the government. And also, Guillermo, I want to make a comment regarding the first question as a provider. We have 2 different harm reduction clinics, and regarding to our transgender population, most of them some kind have concern regarding the use of PrEP and possible interaction with the hormonal treatment, and we explain to them that there's no interaction of that they can use it. We look for several data, and even we have some local data regarding to that, and there's no drug interaction. But it's related to our people who use different substance, abuse for different substance. Maybe the concern that we found is that for them, using PrEP is not the priority. For them, maybe keep them safe alive, get the money for provide food to their home are the priority to them. So when we try to put them on PrEP, it's really hard. And we have to try to provide another thing that maybe they need, that sometimes when they're not HIV positive, we don't have alternative in the area because we are talking about PrEP. So on PrEP service, sometimes we don't have so much to offer to them to keep them on service so they can take PrEP as an option to not get infected.
Thank you. Nothing better to have a doctor in the house. Family, thank you so much, panelists. Thank you all of you to attending the first day 1 to 3 Eastern Standard Time. We will continue tomorrow. You will receive evaluation. We got between 222 to 34. I know tomorrow for workshops and Fridays, it's going to be a whole weight of new people coming in, but we are grateful. Please stand by. You will receive by email an evaluation. And again, we want to be very grateful with the panelists and all the attendees, and we will continue to evolve and overcome all the challenges, because a healthy community is a community that will have a bright future, but will depend on all of us. Thank you, everyone. Love you. Bye-bye.
Bye-bye. Bye.
Puerto Rico.